My name is Carrie Haney, and I'm one of the clinical pharmacists who is a member on the Planning Council. And my current role is faculty with the School of Pharmacy here in Missoula and with the Family Medicine Residency of Western Montana. It's my pleasure to introduce our next speaker, Mrs. Brittany Hobbs. She is the acute pain coordinator for the pharmacy department at St. Patrick Hospital here in Missoula. She currently spends a majority of her time managing acute pain of patients following surgery or trauma. She also has recently become more involved in the palliative care team at St. Patrick and helps with management of pain and symptoms associated with serious and life-limiting illnesses.
There we go. Okay, can everybody hear me? I don't think my voice carries as well as yours does, so let me know if I need to speak up. So as she said, I'm Brittany, and I primarily help manage acute pain, so I tried to target my slides on medications to use for pain to be a little bit more on the generic side and less on drugs of choice for certain disease states. And we'll kind of just go through, and feel free to ask questions if you want clarification on anything, and we'll just get started. And the first thing to mention is that I don't have anything to disclose and no conflicts of interest as I go through these slides. So some of the goals that I'm hoping you guys walk away with would be to become more familiar with the importance of using non-opioids as a part of the drug regimen for managing pain. And we'll kind of review several of the non-opioid medications. But then at the very end, I'm going to kind of go through a tool that has been validated to help those of you use opioids more safely, kind of figure out what the risk versus benefit ratio is when you do need to use those to help manage pain for your patients. So I'm just going to look at something really quick because I thought I moved this slide in my official PowerPoint. We'll kind of go through and see though. So we'll go through this slide. So first of all, we're going to go through patient A is a 25-year-old male, and this is his first day after abdominal surgery. As you enter his room, he smiles at you and continues talking and joking with his family and friends. And after you do your assessment, you notice that his blood pressure is normal, his heart rate is normal, respiratory rates look good. And on a scale of 0 to 10, he rates his pain an 8. So on the patient's record, you must mark his pain on the scale of 0 to 10. What would you guys choose to kind of document how his pain is? Okay. Your assessment above is made 2 hours after the patient received morphine 2 milligrams IV. Half-hourly pain ratings after the injection have ranged from 6 to 8, and he had no clinically significant respiratory depression, sedation, or other side effects that you would be concerned with. He has identified 2 as an acceptable level of pain relief. He has available morphine 1 to 3 milligrams IV every 1 hour as needed. So what action would you guys take to, and I know this is acute geared, but just bear with me. What would you guys choose to treat his pain, knowing that he took 2 milligrams and we haven't gotten below 6? I hear 1s and 2s, any 3s? Okay. So in a similar scenario, you have another 25-year-old male, and again, it's after his first day after surgery. But when you enter his room, he's lying quietly in bed and grimaces as he turns in bed. Your assessment reveals similar results. His blood pressure, heart rate, and respiratory rate all look good, and he's also rating his pain an 8 out of 10. And I'm guessing since you guys answered correctly on the first one that you'll rate his pain an 8 also. And again, knowing how he presented, what dose of morphine would you give him if 2 milligrams, again, didn't get his pain less than a 6, but his goal is a 2? I'll let you guys keep that in your head. So this is the results of a survey that was actually done by a group, and it shows that the patient who is smiling, only 86% of nurses who are assessing the patient's pain actually documented his pain as an 8. So they thought most of them documented it lower since he was smiling and still interacting well with his friends and family in the room. And then only 51% of nurses gave him the increased dose of morphine 3 milligrams, knowing that the 2 milligrams didn't provide enough benefit for the patient. Versus the patient who was actually showing to be like he was actually experiencing more pain, 94% documented correctly that his pain was an 8 out of 10, and 64% gave the 3 milligrams of IV morphine. And one thing that I like during any type of education that I do, I like to emphasize that the clinician must accept the patient's report of pain, and self-report should be the primary source of assessment when possible. So common misconceptions is that the best judges of the existence and severity of patients' pain are the physicians and nurses caring for the patients. And clinicians should use their personal opinions and beliefs about the truthfulness of patients to determine patients' true pain. So obviously a lot of us don't believe that, but there are those out there that do. And so I like to emphasize that we still need to trust what the patients tell us for how they're rating their pain, because they're the only ones that are interpreting their pain and know how it feels for them. And it doesn't mean that we keep ramping up all of their pain medications, but we need to come up with a plan to help them cope with the pain and get them feeling better or able to cope with the pain better. And I might need a little help because I don't think this is my final version of slides. I don't know what happened with that. Okay. So we can keep going and we'll kind of jump in and fill in the gaps. I think this is my rough draft. So we'll jump in because this is a slide from my other set. Before we start ordering medications, it's really important to do the patient assessment and review comorbidities, home medications, pertinent labs, how much medications they've used, when they've used them, also what their expectations are, and in the acute setting, we do route of administration. And this helps you to not only eliminate medications, but also to choose the medication that would be most appropriate for the patient. So kind of going through the types of pain, because that helps us to choose which medications we want to use for the patient. So visceral pain is more diffuse in nature and gets worse on palpitation, and it's poorly localized. So kind of how I explain it to patients is that if you have to use your whole hand to describe where you're hurting, or to describe where you're hurting, that's more visceral pain. And so nerve blocks, epidurals, and opioids are going to be the agents that help the most with that sort of pain when it comes to medications. Versus somatic pain is more localized, it's dull, it's sharp, and you can actually, most patients can take their finger and actually point to exactly where it is it's hurting. And for that type of pain, again, opioids do help, but we can also focus on using things like NSAIDs or other adjuvants, acetaminophen. And then with neuropathic pain, with the burning, stinging, electrical type pain, tingling, numbness, those are associated with things like the postherpetic neuralgia, diabetic neuropathies. And with those, we want to focus in on using tricyclic antidepressants, serotonin, norepinephrine, reuptake inhibitors, topical agents like lidocaines, capsaicin, anticonvulsants like the pregabalin, gabapentin agents, duloxetine, venlafaxine, carbamazepine, lamotrigine, and then opioids. And the opioids, they're on this part because a lot of the agents that are listed above that take a lot of time to titrate up to appropriate doses. And if the patient is having significant pain, then sometimes those opioids can help the patient deal with the pain while we're working on titrating up those other agents over 2 to 8 weeks, depending on the agent. So some alternative treatments for chronic pain would be some of the non-pharmacologic agents like the cognitive behavioral therapy, exercise therapy, and other complementary meditation or medicine such as meditation, yoga, acupuncture. And then non-opioid analgesics, the acetaminophen, NSAIDs, COX-2 inhibitors, anticonvulsants, antidepressants. And then we move into doing interventional therapies and also have biofeedback in our back pocket. So for this presentation, I'm mostly going to focus on talking to all of you about acetaminophen, NSAIDs, COX-2 inhibitors, and the anticonvulsants, antidepressants. The WHO analgesic ladder kind of summarizes up, even this is more geared towards cancer pain, but we're also starting to use it for chronic pain as well as acute pain, where we're trying to focus on going for a multimodal approach to pain and not focusing so much on adding opioids on as first line, which I think has started to happen. So we're looking at starting out with, unless it's contraindicated or the patient has other risk factors, we want to have acetaminophen on board. We want to have anti-inflammatories on board. We want to have the anti-neuropathic agents on board if that patient's having that sort of pain. And then we kind of work up. If that's not enough to cover the patient's pain, then we kind of slowly add on as we go up to the next steps. So the multimodal approach to pain is, again, the administration of 2 or more drugs that act via different mechanisms. The American Society of Anesthesiologists highly recommends using acetaminophen as any part of a multimodal pain regimen as long as it's not contraindicated, and that NSAIDs and neuropathic pain agents should be strongly considered when appropriate, and again, not contraindicated. So going into acetaminophen, the indication for this is mild to moderate, non-inflammatory, nociceptive pain. It has analgesic and antipyretic effects. It doesn't help with inflammation, but it does help with the pain associated with inflammation. So side effects can be hepatotoxicity, but it's usually very well tolerated at appropriate doses. Special populations, we want to just make sure for patients with liver disease or who use heavy amounts of alcohol, or even those patients that have been fasting or haven't been eating much lately, we want to limit the amount of Tylenol that we use for them to 2 to 2.5 grams per day. And then it's the drug of choice in patients who are pregnant. And again, Tylenol or acetaminophen, my apologies, is in multiple combination products, especially over-the-counter products, so just making sure that you're familiar with everything your patients are on and that you counsel them to that effect also, because the big risks associated with acetaminophen are when patients accidentally take multiple products containing acetaminophen, and that's when they're getting the doses that are higher than the 4,000 milligrams per day. So acetaminophen, first-line scheduled medication for all patients without underlying liver disease. It has, again, no side effect or significant effect on inflammation. Its benefits are for pain. And for the maximum dose for the chronic use is 4 grams per day. And there has been some confusion in recent years about what the actual new recommendations are for max dosing on acetaminophen. And part of that confusion came around because Tylenol, the brand name company, put out that they were changing their maximum dosing on their 500 milligram over-the-counter products to say that the max dose was 3,000 milligrams per day. But that did not actually come from the FDA. The FDA still says 4,000 milligrams per day is safe as long as it's used appropriately. And the interesting thing is that for Tylenol with their other products, the 325 and the 650 milligram tablets, those still say max of 4,000 milligrams per day. Another thing that's a common misconception, and I personally encounter it on a daily basis working at the hospital when I tell a patient who's post-op that I'm going to add scheduled Tylenol onto their regimen, and they look at me like, you're going to give me Tylenol, and I just have this giant incision on my belly. And a lot of them will tell me that PRN or as-needed acetaminophen doesn't work well for them. And the key to tell patients is that there's a huge difference between using as-needed acetaminophen versus taking acetaminophen scheduled and on an around-the-clock fashion. So that's a key thing to recommend to your patients is if you're going to use acetaminophen, please take it on a regular basis, such as 1,000 milligrams every 6 hours, or 650 milligrams every 4 hours, or whatever regimen you come up with, even if it's maybe 1,000 milligrams every 8 hours, because taking something several times a day can be challenging. A good trial of scheduled acetaminophen is at least 2 weeks, so please ask your patients to give it 2 weeks of trying it on a scheduled basis before considering it a failure or ineffective. So the toxicity is considered minimal except an overdose, and many advocate for limiting to 3 grams per day in anybody over the age of 75 years old. And then again, I mentioned earlier that we want to do 2 grams or 2.5 grams for some of the other special populations. There is some evidence for GI and renal adverse effects, but it's still considered to be safer than NSAIDs when it comes to those types of effects. And then the evidence for drug interaction to prolong the INR when patients are on warfarin is there, but again, it's still the drug of choice for that group of patients. So just to reiterate for the last time with acetaminophen before we kind of move on, is that, again, when I talk to people, a lot of times I don't hear it running through their head that patients who are malnourished or who have been recently fasting are at risk for having hepatotoxicity from acetaminophen. And that's just because some of those things that help to break down the acetaminophen in the liver, glutathione, gets depleted when patients are malnourished. So, and that kind of leaves the toxic metabolite hanging around in the liver causing issues. Any patients that have regular or heavy use, we want to be cautious with of alcohol, and then pre-existing liver disease, and then if they're on any hepatotoxic medications. So this chart is really beneficial in kind of getting the point across in how some of the non-opioid medications can have similar benefits to some of our opioids. For example, for acetaminophen 650 milligrams, it's been considered equianalgesic to, say, hydrocodone 5 milligrams or oxycodone 3 to 5 milligrams. And then similar with ibuprofen, 200 to 400 milligrams is equianalgesic to hydrocodone 5 milligrams or oxycodone 3 to 5 milligrams. So something to just keep in mind as we're, again, trying to go through that multimodal approach with patients, attacking the pain from multiple different mechanisms of action can really add up for the patient and help us to keep doses down and therefore reducing the risk for certain side effects. So we're going to move on into our NSAIDs, and to start out with special populations for NSAIDs. So patients at high risk for GI bleed, it is generally recommended to use celecoxib or meloxicam, and I'll kind of show you a slide for that in a minute. But then you can also add on a proton pump inhibitor such as pantoprazole or omeprazole for a little bit of extra protection. You want to avoid in patients with a history of cardiovascular events, congestive heart failure, hypertension, or a history of an MI, because it may increase blood pressure and overall risks for another cardiovascular event or another MI. And then naproxen, if you need to use an NSAID for those types of patients, is generally considered to have less risk associated with cardiovascular issues. Caution in mild renal impairment or concurrent nephrotoxins. The NSAIDs, they can cause issues with the kidneys, and it's typically reversible, but the patient may not necessarily get back to their baseline. So it's really important to use caution, and then if you, again, do have to use an NSAID for these patients, to try to use the lowest dose for the shortest amount of time. We want to use caution with asthma or respiratory distress when it comes to NSAIDs, and then we want to avoid in patients who have platelet defects or thrombocytopenia because of the COX-1 effects on platelets. Special consideration in children and pregnant or lactating women. We want to be careful at certain ages for children and also certain trimesters for pregnancy. And then it's contraindicated in severe renal dysfunction, current bleeding or trauma, post-CABG surgery, And then one thing that's really important as we start having more and more patients going through gastric bypass surgery is it's important to know that NSAIDs are contraindicated in patients with a history of gastric bypass, and it's a lifelong thing. It's not a short-term contraindication. It's something that we don't want to use ever again in them if we can help it. So this is just a nice chart to help break down the different classes of NSAIDs. And one thing that is important to know is if a patient has an allergy to one NSAID, it is very difficult to say that they won't have a reaction to some of the other NSAIDs. And if you need to use an NSAID, there is some literature out there to say that you can do the really small dose trial of something to see if they have a reaction and then slowly increase the dose. But again, just because in NSAIDs, just because they're in a different subclass, it doesn't necessarily mean that you can definitely get away with using another NSAID if they have an allergy. There hasn't been a whole lot of research on that topic, and it's one that I just recently came across with a patient, so I thought I would share that with all of you. So NSAID's role in therapy, it's antipyretic, anti-inflammatory, and it helps with analgesia. It's really helpful for bone, dental, and muscle type pain. It's synergistic with acetaminophen and opioids, and again, it has the multimodal approach to help reduce overall doses needed to help treat pain. It is ineffective for neuropathic pain when it doesn't have inflammation, so keep that in mind. NSAIDs do have a ceiling effect, so you can reach a max dose where if you go above that, you're only going to increase the patient's risk for side effects and not necessarily offer them any additional benefit for pain. And often patients will respond to one NSAID even if they've failed on trying multiple different other ones. So if you've tried 2 or 3, keep going, you might find a successful one. For osteoarthritis, an average of patients feel about a 30% decrease in their pain with a 15% increase in function. So that's important to notate. And then the half-life of the agent correlates with the adverse drug reaction risk, especially in our elderly patients as things start to accumulate. You want to use the lowest dose possible for the shortest duration needed to gain symptom relief. And I believe there should be a slide coming up that kind of gives percentages for duration of therapy of the risk. And then NSAID discontinuation due to an adverse drug reaction is about 10%. So NSAIDs act through the COX enzymes, and the primary mechanism is to inhibit the COX enzyme, resulting in blockage of prostaglandin synthesis, and there are 2 different forms, COX-1 and COX-2. So COX-1 is the one that's more associated with platelet aggregation, which is why with our non-selective NSAIDs, we typically get prolonged bleeding times and are concerned about that and stopping it a few days prior to surgery. Important role in the GI tract, kidneys, and platelets, and it does produce prostaglandins with beneficial effects such as regulation of blood flow to the gastric mucosa and kidneys. So when we use NSAIDs and it blocks this pathway, that's why we get the increased risk of the GI adverse events and the kidney dysfunction. With COX-2, its primary form is active during inflammation and pain. So when we developed COX-2 inhibitors, such as celecoxib, it was hoped that we would improve pain and we would limit the side effects associated with the NSAIDs. But unfortunately, something that came of that is that we ended up with more cardiovascular events. And we still, with the COX-2s, get kidney side effects, so we don't miss out on that with COX-2 selective agents. So this chart is just to show you which agents have more COX-2 versus COX-1 selectivity, and it also gives you a good idea. The more COX-2 selective something is, the higher the risk for the cardiovascular side effects versus the more COX-1 selective something is, as we go down towards the bottom of the table, is the more increased risk of GI risk. So something that's been interesting to me is meloxicam is one of our considered non-selective NSAIDs, but it's actually shown to be slightly more selective for COX-2 than even celecoxib is. So GI toxicity is the primary adverse drug reaction for our NSAIDs, and the prevalence is 10 to 20%. And we have about 100 to 400,000 hospitalizations per year, which can add up to upwards of $1.6 billion per year. There are approximately 16,500 deaths associated with NSAIDs per year, and the number needed to harm is about 1,200 to cause one death due to GI toxicity with NSAIDs. And there's about 2 times the risk of GI toxicity versus the general population who's not on NSAIDs. So this is the part that I was telling you about for estimated risk for NSAIDs as far as duration and side effects. When you treat for 3 to 6 months, the patients have a 1% risk of getting an ulcer, versus it goes to 2 to 4% per year, and then 14 to 31% with long-term use. So that's why we want to do the lowest dose in the shortest time possible to treat pain with NSAIDs. So this is a table that kind of helps to delineate if your patient is at low, intermediate, or high risk for GI events. Then that kind of helps you delineate what you should do. So if you have a low-risk patient, usually less than 65, no cardiovascular risk factors, and they're not on any other blood thinners or aspirin, then you can do a traditional NSAID for the shortest duration, lowest dose. As you go up, your patient gets a little bit older, they still don't have a complicated history with GI ulceration, their CV risk is low, and they might have concurrent aspirin on. Then you can still use an NSAID, but you might want to consider adding on a PPI or an H2 blocker like famotidine. Misoprostol is an option. And then the other option, since again they have a low CV risk, is that you can add on instead once daily celecoxib, and you can consider adding on a PPI to help with the GI toxicity. It's considered low with celecoxib again, but you could still add it on just for extra protection, especially since they're older than 65. And then as you get into the high-risk patient population, so they have cardiovascular disease potentially, they might have a history of GI issues, they're very elderly, a history of heart failure. You want to consider using acetaminophen instead of NSAIDs, and you want to try to avoid chronic NSAID use. But if you absolutely feel that this is going to offer your patient a lot of benefit, then for a very, very short duration, you can consider adding on naproxen, as it's considered to have the lowest cardiovascular risk out of the NSAIDs. Once daily celecoxib, if your patient doesn't have the significant history of cardiovascular disease, but they may have the significant history of GI ulceration, might be a better option. And then you can always consider a topical agent that would say they have pain with their knee joints. It's a small area, you can use a topical agent, and then they don't absorb a lot into their overall system. And this just kind of summarizes risk factors associated with the GI toxicity that we've mostly talked about already. So if your patient develops an ulcer while on an NSAID, number one, it's important to test for H. pylori and treat that if they come out positive. But some of the ways to go about it, if the NSAID is stopped, then you would treat with the high-dose H2 blocker or standard dose proton pump inhibitor. Again, you would just follow typical ulcer treatment. If you choose to continue the NSAID, then you would want to go with the proton pump inhibitor. And studies have shown that the high-dose PPI hasn't been more effective than standard dosing in clinical trials, so you could just use standard dosing. The ulcers can typically heal in 8 weeks, but it may be longer if they're H. pylori positive or if you continue the NSAIDs. So then you'd want to obviously continue with the PPI or H2 blocker as appropriate. So COX-2, we've kind of talked about it a little bit, and we covered that slide. So going into the cardiovascular toxicity, There is a day considered to be Black Tuesday when the New England Journal published their information regarding the COX-2 agents, and we lost a few off of the market. So with Vioxx in the approved trial was shown to have a 1.92 relative risk versus placebo in patients with colorectal adenoma cancer. And the risk became apparent within 5 months, and they stopped the trial and pulled the medication. The same is for I'm going to say the brand name, the Bextra, 1.9 relative risk ratio, and that was in treatment of post-op pain following CABG surgery. And then they did a study on the celecoxib, but it was a smaller study than the approved, and that showed 2.3 relative risk ratio at 200 milligrams BID, and that it increases to 3.4 at 400 milligrams BID, and that was in the adenoma prevention with celecoxib trial. So something to keep in mind. And this is just another illustration kind of reinforcing which ones are more COX-2 selective versus COX-1 selective so that you can go through and pick the most appropriate agent for your patients as you go through their history and see what their risk factors are. So GI toxicity, a decreased risk compared to the non-selective NSAIDs, as we talked about. In one of the studies that was done showed that with celecoxib, there was a 71% reduction when they went in endoscopically to detect ulcers at 3 months, and the number needed to treat was 6. Primary reason for discontinuing was dyspepsia and abdominal pain with celecoxib, but when you look, the dyspepsia was 8.8% for celecoxib versus 10 to 12% with other NSAIDs, and then it was 6.2% still with placebo. Ulcers do still occur with COX-2 agents, it's just not nearly as commonly as it is with the non-selective NSAIDs. So it doesn't have any effect on platelet aggregation or bleeding time. So for me in my practice, it's really nice. We use it in some of our patients, for instance, post-op knee replacement or hip replacement, because it doesn't prolong the bleeding time, so then we don't worry so much about it bleeding into their surgical wound and increasing their risk for an infection. It's no safer for the kidneys, as I mentioned. And then for sulfa allergies, it is listed as a contraindication in the labeling, but something that's interesting is the incidence of allergic reactions was evaluated in 3 meta-analyses, and the risk of cross-reactivity with other sulfonamides is no greater than with placebo. So this was a nice table that I came across for your patients with osteoarthritis who might also have underlying cardiovascular disease. And it's kind of a stepwise approach to go through picking agents for those types of patients. And along the side, it kind of helps walk you through also. So you want to select patients at low risk of thrombotic events, prescribe lowest dose required to control symptoms, and consider adding on aspirin and a PPI to patients at increased risk of thrombotic events. If you end up starting an NSAID on one of these patients who, again, have cardiovascular disease, you do want to do routine monitoring of things like their blood pressure, edema, their renal function, or their risk for a GI bleed so that you can reassess this regimen at any time, because again, this is a high-risk patient population for using NSAIDs in with cardiovascular disease. So the probable reason for cardiovascular disease with COX-2, or with NSAIDs in general, no antiplatelet effect without COX-1. The recommendation is add daily low-dose aspirin to COX-2 if it's a cardiac patient. The naproxen conundrum. So there are 3 studies in 2002 with naproxen, quote unquote, protecting against thromboembolic cardiac events and acute MI. Then December 2004 and July 2014, there were studies that showed an increased risk. And then the the thought behind this is it probably depended on the dosing that was used. So high doses of naproxen probably are associated with more cardiovascular risk versus the lower doses, for instance, 220 milligrams BID or PRN, have been shown to be maybe a little bit safer cardiovascular toxicity-wise. So also keep that in mind, that naproxen across the board isn't necessarily safer for your cardiovascular risk patients. There may be a dose limit on that, and I think that that information is still kind of out there being figured out. And this is just talking about with dosing-wise for osteoarthritis, 100 milligrams of celecoxib or 50 milligrams BID effective in osteoarthritis. Remember back to the slide that showed that it had a higher relative risk for cardiovascular issues, yet it's still on the market. We just want to be very cognizant that that risk seems to go up the higher the dose. So if you can get away with using a very low dose of celecoxib to treat, for example, osteoarthritis, then that would be the safest thing to do for your patient. So this slide comes from the Circulation Journal, and it summarizes, so there was some thought out there over the last several years that as long as we used NSAIDs in our cardiovascular risk patients for a short amount of time, that they were considered to be safe. But they published an article, I believe it was in 2012, that actually showed this information. So the patient population was anybody who had experienced an MI in the last 5 years. They did a study with each of these different medications and looked at the increased risk of death following treatment duration of, and then we'll fill in the blank for each of the medications, and then the hazard ratio. So for instance, with celecoxib, if a patient was on that for 14 to 30 days, their hazard ratio was 2.33 versus diclofenac from day 1, so even after a single day, increased their hazard ratio up to 3.52. And one thing to note is that diclofenac is considered to be the #1 prescribed NSAID in the world. So we really need to be paying attention to the cardiovascular risk and the history of an MI in our patients when prescribing this medication. And then ibuprofen, when used for longer than a week, hazard ratio is 1.57, and they didn't find an association necessarily with duration with naproxen. But it still has a hazard ratio of 1.63. So nephrotoxicity. I think we're all familiar with NSAIDs and the risk for renal failure. The risk factors, so chronic renal insufficiency, we want to be really cautious in our elderly patients and our diabetic patients. Avoid use if the creatinine clearance is less than 30 to 50. And typically, in my practice, we really try to stay away from it as the creatinine clearance gets close to 50. Decreased perfusion. So we want to be careful in our congestive heart failure patients, our patients with hypotension and dehydration. And then, again, the renal failure is typically reversible, but they may not necessarily get all the way back to what their baseline serum creatinine is or was. Hepatotoxicity risk. So this is something that's not necessarily talked about very often in association with NSAIDs. It can happen, it's very rare, and it's typically reversible. We do sometimes see an increase in LFTs in 10 to 15% of patients. It rarely leads to full-blown drug-induced hepatitis. Diclofenac has been more reported cases, and again, it comes out that it's the most widely prescribed NSAID in the world. And then it's contraindicated in patients with severe cirrhosis, and this is also because of potential hematologic and renal complications. It's considered that acetaminophen at less than 2 grams per day or 2 to 3 grams daily is considered safer than using an NSAID on that patient population. So we are going to move into neuropathic pain, and to do that, because I'm guessing some of my slides aren't here, I'm going to grab my other sheet so that I can have talking points for you guys. Luckily, I have a paper copy. So this slide is just showing you the number needed to treat for neuropathic pain with all the different drug classes. So with your tricyclic antidepressants, the number needed to treat is the smallest, and it's typically considered the first line class of medications for treating neuropathic pain. And then as we go down, so if you see that valproate and carbamazepine, lamotrigine, phenytoin, they have a fairly low number needed to treat, but we don't use them as our first line agents because they have a lot of toxicity issues attributed to them. So we typically use them a little bit further down the line. Say if our TCAs or tricyclic antidepressants aren't effective enough, or the gabapentin, pregabalin, SNRIs, then we might look into considering using carbamazepine, lamotrigine. But again, they're not considered our first line, even though they have a low number needed to treat. Opioids are up there, and they have a reasonably low number needed to treat. And again, we use those more as bridge therapy for treating neuropathic pain because all of these agents take a lot longer to titrate up to effective doses, which we'll get into. And so it's just a nice, like I said, bridge therapy while we're getting effective doses. All right, so as mentioned, the tricyclic antidepressants are considered first line. They help to suppress pain signaling, and they offer analgesic effects. And also a nice added benefit is a lot of our patients with chronic pain also have, say, depression associated with it. And so this can help elevate the mood or improve the mood, as well as help with their neuropathy. So tricyclic antidepressants they're useful for neuropathic pain, as we've talked about. They're useful for some cancer pains, especially maybe a patient's gone through chemotherapy and is having neuropathy from some of their treatment. Tricyclic antidepressants can be useful for that. It can also be used for some non-neuropathic pain with certain symptoms, such as insomnia, depression, visceral pain. And the ones that are shown to have the most benefit analgesic-wise would be amitriptyline and nortriptyline. Some of the common side effects are going to be dry mouth, sedation, urinary retention, constipation, orthostasis. And then something that's very important to know is they also have cardiovascular effects. They increase blood pressure, and they can also have an effect on conduction blockade. So we want to, again, look at the patient's medical history and choose appropriately. Maybe that rules TCAs out for our patients with a cardiovascular history. Also, a very, very important thing to note about our tricyclic antidepressants is they can also lower the seizure threshold. So something to be aware of also when you're looking into a TCA for a patient. So this slide kind of lines out, tricyclic antidepressants are separated out into secondary amines and tertiary amines. And this kind of just helps you to see which ones have more side effects. And that can help you choose for your patient what might be more appropriate. So say your patient's having a significant amount of insomnia, you might want to look at choosing a tertiary amine such as amitriptyline and dosing it at bedtime so that you're helping with their pain, but you're also helping them sleep a little better at night. On the other hand, you might have an elderly patient and you wouldn't want to use a tertiary amine because maybe it has more anticholinergic effects, and that can increase the risk for a fall, blurry vision, constipation, so again, and hypotension. So again, this is more so to delineate to help you choose for your patient scenario which of the tricyclics might be the safest option, but also you can use some of their adverse events to your advantage depending on what your patient has going on. So moving into anticonvulsants used for neuropathic pain. I'll just bring up this slide, but I added some more since this first one was drafted. So anticonvulsants, they inhibit the neural hyperexcitability, and they can help to relieve that lancinating and stabbing pain. The most common ones that and are considered the safest are going to be the gabapentin and the pregabalin, as I mentioned. And again, some of the other ones have more serious side effects that typically have them further down the list. So with gabapentin, it's generally well tolerated. Serious side effects are considered to be rare. And one thing that's interesting about it is it's been shown to have doses that are effective anywhere from 100 milligrams a day up to 3,600 milligrams per day. And it's considered to have nonlinear kinetics, which plays into why its dosing is a little bit more difficult to figure out. So we have to start low and go slow, for example, because it can have side effects such as blurry vision, dizziness, and the lower that you start out and the slower that you go, it helps to minimize those risks, and it also helps the patient's body to adjust to having the medication and to hopefully experience fewer of those side effects. Usually you can see positive results from starting gabapentin in as soon as 2 days, but you're really not going to see the full benefit of it for typically considered 3 to 4 weeks. And during that time, you're still going to be titrating up. But again, gabapentin is going to take a little bit longer because of those nonlinear kinetics to see where the patient's going to start getting benefit. So moving into pregabalin, I'm not going to spend too much time on this one. Its kinetics are more linear than gabapentin, so it's typically considered easier to titrate up to more effective doses. So it makes for easier titration, and a lot of times patients see a little bit quicker results from using pregabalin because it's easier to titrate it up and it's faster to titrate it up. The downside is it's typically more expensive than gabapentin is, so that's where you're kind of weighing your which one you start with on that side. So moving into selecting a first-line drug for peripheral neuropathy, we are looking at patients with glaucoma, orthostasis, cardiac issues, hypertension, suicidal ideation, weight gain concerns. You want to avoid the tricyclic antidepressants and consider maybe gabapentin, pregabalin. If they have hepatic insufficiency, I didn't talk about SNRIs in here because I think I'm going to run out of time. But you want to look at avoiding duloxetine because it's associated with more hepatotoxicity. If you're concerned about peripheral edema for your patients, then you may want to try something other than pregabalin. Cost concerns, again, you may want to avoid pregabalin. Duloxetine also is considered to be expensive. Erectile dysfunction, venlafaxine may be your better option to cause fewer side effects in that regard. Insomnia, then maybe choose the tertiary amine TCA, as we talked about. And then depression, you want to choose one of the antidepressants to help treat the peripheral neuropathy so that you can also help treat the depression. So an SNRI, such as the duloxetine or a TCA. This table is really nice because it helps to line out starting doses for a lot of the different agents, as well as titration schedules, maximum doses, and then what's really important is how long do we need to try these medications before we consider them to be a failure. So the majority of them are in the 4+ week mark, similar to what we see with antidepressants in general when we're treating depression. We're titrating doses up and trying to see what effects they have for the patients. So nortriptyline, desipramine, the TCAs, most of the TCAs are dosed very similarly, starting at 10 milligrams again at bedtime because a lot of them are sedating. And you can titrate up to as much as 150 milligrams per day, but you typically need doses that are quite a bit less than, say, what you use to treat depression when you're treating neuropathy, so keep that in mind. And an adequate trial would be 6 to 8 weeks. Duloxetine, again, is 4 weeks. Venlafaxine, 4 to 6 weeks. Gabapentin, so starting out as low as 100 milligrams 3 times a day, especially in your patients who are a little bit on the older side, starting lower is definitely a safer option. And then I just got the 5-minute mark, so we're going to move on because you guys can see all of the slides. So now we are going to move into briefly talking about opioids. So one thing that I've kind of noticed in some of the literature or pain management advocates out there are starting to talk about is considering to use the word opioid when you're talking about opioids, especially with patients, instead of the word narcotic. Narcotic can come across as being very abrasive. It's typically associated with, say, a narcotics division, the DEA, using our opioids or benzos or things like heroin and cocaine, rather than opioids, which we're using in a medical manner to help treat pain. So something to be aware of, and it can help patients not feel that stigma that's associated with using opioids to treat pain. We get a lot of patients in the hospital system that try to bear through pain rather than using the opioids because they're afraid of addiction or they're afraid of the stigma associated with being on an opioid, even though they just had a major surgery. So I try to emphasize with the healthcare workers that we have around to please use opioids and benzos instead of lumping everything together and calling it a narcotic. So some statistics to dump into really quick. So greater than 30% of Americans have a form of chronic or acute pain, and greater than 40% of older adults have chronic pain. And in 2014, 245 million opioid prescriptions were dispensed, and 65% of those were for durations less than 3 weeks. So a lot of opioids out there. So there were 44,000 drug overdose deaths in 2013. And again, this is some of the more recent literature I was able to get a hold of at this time. And 30% of those were secondary to opioids. 2.5 million adults in 2014 with reported opioid addiction, and the major source of diverted opioids were from physician prescriptions. So how do we kind of try to weigh risk versus benefit with our patients? And we'll kind of get into that. Some misconceptions that are out there is that addiction is the same as physical dependence. Addiction is simply a set of bad choices. Pain protects patients from addiction to their opioid medications. Only long-term use of certain opioids produces addiction. Only patients with certain characteristics are vulnerable to addiction, and medications-assisted therapies are just substitutes for heroin or opioids. So we kind of want to get away from that, and I don't have time to dive into that quite as deeply as I was hoping for. So we're going to move on to this tool that was developed by the VA and then went on to be validated, and I'm spacing on the group that did it at the moment. I think it's delineated in a couple of slides. But it's a table that you can go through asking patients questions so that you can figure out the factors associated with the risk of opioid overdose or addiction. So you go through and figure out the answers to each of these questions, and then they have the scores lined down the side that you're able to add up to determine what their risk is for a possible overdose or their risk factors for addiction. And I can kind of let you guys read through this, but some of it is in the last 6 months, have they had maybe a substance abuse disorder, and that includes to multiple medications, or hallucinogens, cocaine, etc. Do they have a history of bipolar disorder or schizophrenia? Do they have a history of a stroke or another cerebrovascular disease, chronic kidney disease with significant renal impairment, heart failure, non-malignant pancreatic disease, COPD or some other chronic pulmonary disease, chronic headache. And then does the patient consume, and then you add up the score for any of these other medications that might be used in conjunction with not only the opioids, but some of the other more sedating agents. And that can even include something as simple as an antidepressant. And then once you add everything up, it's separated out into risk classes. So if they scored, say, 0 to 4, their average probability of having the overdose versus addiction potential is 2%, versus if they score greater than or equal to 42, then their risk is an 83%. So you probably don't want to use an opioid for those patients. But anyways, I was reading about this and I thought, and it's validated it, and it was just included in a study that came out in the last couple of months. They referenced it, and it just seemed very useful for those of you in the chronic pain field it was very brief, asked to the point questions, and then it allows you to add up the risks and gives you an idea of how likely the patient is to suffer from even an accidental overdose or what their risk is for addiction. So I'm pretty sure I'm running out of time. So really briefly, common opioid medications. One of my residents created this slide and thought it was pretty hilarious. So things that are commonly associated with opioid use: nausea, vomiting, constipation, CNS issues, respiratory depression, pruritus. Out of all of those, constipation is the only one that doesn't go away the whole time that you use opioids. So before we move on, because I don't think I have the slide at the end, is if you're starting an opioid on a patient, even if it's PRN, please, please, please start them on scheduled stimulant, laxative, and a stool softener. You need both, and then you can taper it or titrate it however you need to get the results for the patients. But they do need both. A stool softener isn't going to help things move through like it needs to. And a laxative isn't going to help get things soft and a little more comfortable as it moves through. So hydrocodone, I'm just going to point out really briefly the more important thing to think about with this one, because we're all very familiar with hydrocodone, I'm sure, is that it can interact with many other medications. It's less than oxycodone, but some common ones are barbiturates, carbamazepine, rifampin, azoles, amiodarone, and antivirals. Most of these decrease the efficacy of hydrocodone and oxycodone, so something to keep in mind if your patient has one of these medications on board. And it's also going to be listed here on oxycodone. And again, oxycodone interacts with these medications even stronger, so keep that in mind. Hydromorphone typically has less histamine release compared to morphine, so that's beneficial. It's a better choice typically for elderly and renally impaired patients when you're looking at comparing it to morphine, because it has less active metabolites than morphine does. And then fentanyl, we use the injection more so where I am. It's really nice because it doesn't have any active metabolites for that reason. And then in the chronic world, we want to make sure that we're only using fentanyl patches if the patient has a significant tolerance to opioids, which is typically considered to be that they've been on morphine, 60 milligrams daily, or an equivalent for at least 7 days. And then morphine side effects, it's associated with more nausea, more itching. It can cause hypotension, and all of that is more so related to the histamine release. And we want to be really careful in our elderly patients and our renally impaired patients. The literature out there basically says to use morphine with caution in renal impairment, but none of the studies at least none that I've come across yet, give you kind of that line in the sand of if your creatinine clearance is less than this, then stay away from it. So typically kind of the rule of thumb that we follow in my practice is that we start to steer clear of it when the creatinine clearance gets less than 50. Just because we notice in the acute setting that we start seeing a little bit more confusion, et cetera. But again, that's my practice, and the literature that I've seen doesn't actually give you a line in the sand for creatinine clearance cutoff. And this one does have the active metabolites M6G and M3G. They can be dialyzed off, but it's also very difficult to dialyze off if you use it in a patient who's on dialysis. And that has to do with the metabolites crossing the blood-brain barrier, and you're only dialyzing off what's kind of in the bloodstream, and then it equilibrates after dialysis, and so more comes out, and then the next dialysis session. So again, something to keep in mind is that it's considered dialyzable, but it's a slow process. And then tramadol, really quick, and then I think I'm finished, it's in its own class. It's not necessarily considered an opioid, but it still acts on mu receptors, and then it also acts on serotonin and norepinephrine. It's generally well tolerated, especially we use it a lot in our elderly patients. But one thing to keep in mind is there's some literature coming out that tramadol can contribute to hypoglycemia, and they're starting to see, especially our elderly patients, showing up in the ER with hypoglycemic issues. And they're still working out the exact mechanism, but some of the things out there is that both the mu opioid receptor as well as the serotonin levels play a role on hypoglycemia, and tramadol affects both of those. It's contraindicated in creatinine clearance less than 30. It does increase the risk for seizures, so be cognizant of that in your patients. Respiratory depression is rare, and it can still cause a dependence similar to opioids. So it's not free of that like was originally advertised when tramadol first came out. And I think with that, I am finished. If there are any questions out there for me. And sorry I flew through that last section a little fast.
I guess I have a quick question.
Yep.
So on the slide where it had the varying risk for an opioid overdose, I imagine at some point you'd say, okay, any higher I'm not going to prescribe it, any lower I will prescribe it. But on the top end of the I will prescribe it, is there, should we be considering prescribing naloxone with those higher risk patients that we're still prescribing it to be taught to the family members in case there's an accidental overdose, or if a child in the household happens to get into it if it's not properly locked up?
Good question. So it's starting to be talked about a lot more that prescribing naloxone to patients on opioids is just a safe thing to do, because accidents do happen, or maybe they start a new medication. So anytime you're starting an opioid, it's definitely worthwhile to consider ordering naloxone for the patients to have on hand also.
Short of having you as a consultant in the office all the time, do you have any recommendations for the best app or decision support for obtaining this kind of information in a busy practice setting?
I personally keep, and I have it out in my car that I can bring to show you, but I have a nice book that was put together that covers lots of different, I'm obviously old-fashioned where I still look at a paper book, but I have a really nice book. It's Pain Assessment and Management, and it goes over just about every topic you could think of, and describes different scenarios and what you could do. That's kind of my go-to that I have, and then the rest of it I can reach out and see what else other people use. Sorry, that wasn't super helpful.
Do you have an opinion about Hippocrates?
Hippocrates, I haven't used that in years.
Or anything else?
So at the hospital, I know we use UpToDate a lot, which has LexiComp in it, which I really enjoy. But for me, UpToDate is readily accessible, and it's the one that I use the most personally. And it's free to me at the hospital, so that's... But I do really like it. Are there any other questions?
I had a question.
Yeah.
If I did the math right, I couldn't help but notice that the number of overdose from opioids per year was almost exactly the same as the number of deaths from GI bleed from NSAIDs per year. And I just want to comment on that we're all up in arms about opioids and how dangerous they are, but NSAIDs, I mean, they're still over the counter.
Mm-hmm.
And I don't know, I think that deserves some spotlight. NSAIDs are pretty dangerous.
I definitely agree, and that's part of why I chose to put such a focus on talking about the GI toxicity and cardiovascular risks with NSAIDs, because they are readily available to patients without prescriptions. And I knew we'd have a wide variety of audience members out there to offer up education. But there are a lot of risks associated with NSAIDs, so we do have to be careful of who we recommend them to. But they do also have a lot of benefit in those patients that they are considered on the safer side for.
And also, and just on chronic opioid therapy, it seems like quite commonly if you get up to a certain dose, it's really worthwhile to think about switching the medicine. So if you're using one short-acting, switching to another, because I see patients all the time who can go to a lot lower dose if we transition them, drug holidays, those kinds of things. So just to keep your open mind that if you're getting higher doses, maybe it's time to hit the receptor differently, in addition to all the multimodal stuff we're hearing about outside of just pharmacology.
On the East Coast, there are increasing reports of abuse of gabapentin, and we're seeing it also here in this state. Do you have any comments on that?
I do not. Since I'm more on the acute side of things, I haven't come across that information yet. Oh, and Carrie. Carrie can speak to that a little bit more.
I'm a pharmacist in Missoula, and we are definitely seeing that at our clinic setting. So it's something to have on the radar screen since it's a non-controlled substance. It's not reported through the drug registry in the state, and we've had a lot of issue. It looks like it's mostly like polysubstance abuse, so it's not being reported that people are only using gabapentin alone, but it's usually being used to enhance other substances that they're taking.
Any other questions or comments? Okay, thank you.
Well, good afternoon, everyone. My name is Jean Branscombe, and you're doing a great job. It's after lunch, and everyone's still awake. That was a fascinating presentation. Thank you so much for sharing that. Again, Jean Branscombe, and on behalf of the Montana Medical Association and Montana physicians, we appreciate your attendance at today's meeting. This is a very important topic to the area of medicine, and we have had wonderful speakers so far today, and that trend's going to continue on with your next speaker, Dr. Camden Neeland. Dr. Neeland is the medical director of one of the most comprehensive pain centers in the nation, right here in Montana. And I must comment how blessed we are in Montana to draw this kind of expertise and talent in our state. He practices again in Kalispell, and he's board certified in anesthesiology and pain medicine. I got to know Dr. Neeland over the past 3 years as the MMA dove deep into the topic of ending opiate abuse in Montana and making sure our patients are adequately cared for when they're suffering chronic pain. Dr. Leland was one of the leaders of this effort to build a toolkit aimed at family medicine physicians and at all other providers to ensure, again, patients suffering chronic pain have access to care through a tool that's easily accessible. This includes a no-cost online educational module featuring Dr. Neeland and Dr. Mintel, two of our speakers today. We challenge all of you who are participants today to take time to take advantage of that website and those educational modules. It's knowyourdosemt.org. It's geared toward what's happening in Montana, the nuances of practice, and includes patient information as well. If you'd like more information on that, we do have a booth out front. And speaking of education, Dr. Neeland has a wonderful education and training background that really helped with this particular effort. This includes a fellowship in pain management. It also included some time and a stint back in the University of Oklahoma, where he earned his undergraduate degree, and he also attended the College of Medicine there. So he is definitely a Big Red fan. Now, I have to tell you something about me, and that's the secret that I hold here in Montana, and it's I'm married to an Okie. I have a husband who's a redneck, and I think once you are living in Oklahoma and you go through that training, you're going to have a little bit of redneck tendencies. So I just want to prepare you all for that. And so I want to give you a short lesson just in case he gets into that redneck mode and give you a couple of things, just 3 hints on some language that if he starts speaking redneck, you'll understand what he's talking about. So if you hear the word bard, that means borrow in Montana, like the nurse borrowed my stethoscope. Or if he says months, that's really a calendar division in the state of Montana. So he might say your treatment will occur over several months. Boz is another thing that might come out of his voice, his speech. And well, frankly, if I don't move on with this introduction, our conference boss, Mark Mintel, is probably going to pull me off the stage. So please welcome me, and welcome me to introduce Dr. Neeland to the stage, who ain't been in Oklahoma for months. He is an expert whose techniques are borrowed, and he's the boss of the topic of interventional pain management. Dr. Neeland.
I don't think this, oh, there it goes. Thank you, Gene. I'll do my best to keep the Okie talk down. No, actually, I was kind of fortunate not to develop much of an Oklahoma accent because my dad was from Maine, and so, but anyway, thank you very much for having me. It's a pleasure to be here again. Thank you all for coming. I wanted to spend a little bit of time today just going through some little specific issues with patients where interventional techniques, both diagnostically and therapeutically, can be employed in ways that you may not typically think of. You know, when we think of interventional stuff, oftentimes we think of epidural steroid injections, and that's about it, but that's really a fraction of what can be done. So, let's see. Boom. Cool. So there's all the alphabet soup, but I'd like to talk a little bit about how I got here. When my wife was 19 years old, she was hit by a drunk driver, and she injured her back. And she suffered from pretty significant back pain for about 1.5 years, during which time she went through all the standard treatment that a lot of our patients do, primary care, chiropractic, et cetera. And it wasn't until she met a pain specialist that the correct diagnosis was made. Ultimately, she did end up having a fusion. Fortunately, she's doing really well. This was many years ago. But that's how my interest in chronic pain management started. But the reason I'm here is that I'm passionate about helping people reduce their suffering. That's why, as medical director of the Montana Center, we have a lot of ways to treat pain. It's a very complex disease, and it requires complex treatment for many people. Interventional stuff is just part of it. You know, as Liam Neeson said, I have a very particular set of skills. This is my particular subspecialty skill set, but this is the easy part of my job. The hard part of my job is sitting in front of patients every day and trying to figure out what to do to reduce their suffering. even though I'm blessed to have a very comprehensive clinic to help, it's still tough. But anyway, let's talk a little bit about interventional pain. So we'll talk about when to think about interventional stuff, both diagnostically and therapeutically, a lot of specific little techniques and pearls that you can think of when you see your patients, and then we'll end with kind of a brief mention of kind of the relative risk of this stuff. So first of all, in my practice, interventional techniques are used diagnostically about 50% of the time. So oftentimes patients will come to our practices with a diagnosis of lumbago, and that is inadequate. So we use interventional techniques such as diagnostic facet injections or trigger point injections diagnostically or selective nerve root blocks to try to really isolate, well, is there an identifiable pain generator? And if so, how do we treat it? And until we know that, it's obviously difficult, if not impossible, to formulate a good treatment plan. So the other role, obviously, is with acute pain. Usually, I don't see that type of patient. However, obviously, if you have a patient who has a suspected disc bulge pressing on a nerve root, that's a pretty significant acute pain that can be treated interventionally. Another obvious trend that we'll talk about is we're looking for more options for chronic pain, primarily because what we've been doing with chronic pain for a long time hasn't worked very well, and we now know that at least from a utilitarian standpoint, we're probably doing more harm than good with opioids, although they do have a very important role in chronic pain management. So this is just another tool to use if opioids aren't working well. So I mentioned the acute pain with the identifiable radiographic target already. For example, the disc bulge, very important role for interventional techniques. That's when to employ it early. The later employment of interventional pain is usually the result of either a failure of other modalities or a lack of access. And in this state, that is an issue. There are just a handful of board-certified interventional pain specialists in this state. And I appreciate the difficulty that those of you from rural communities face. Some of the things in here that I'll talk about with interventional pain techniques are actually things that you can employ if you are doing simple trigger point injections. So we'll talk a little bit about that. So even when somebody like me isn't available, there are some things that can be done without specialty training. Another thing that people don't think much about in terms of interventional techniques is their role in breaking that pain cycle. For example, I always think of a patient I had, probably a year or two into my practice, who was literally in the hospital bedridden because of severe spasm in her low back. And she had had trigger point injections and it just didn't quite get it. And they consulted me to see the patient, and I diagnosed it as being spasm of her quadratus lumborum. And the reason they hadn't gotten it with the trigger point injections is that it was too deep. You can't really do them blindly. So I took her and did a fluoroscopically guided quadratus lumborum injection, and she literally walked out of the hospital that afternoon. But it highlights the importance of using these types of techniques to break a pain cycle and get people moving again. Because one of the things that will come up in a lot of chronic pain topics these days is the importance of both movement and mental behavioral health techniques. I tell patients all the time that if I could pick only 2 things to do to treat chronic pain and help the greatest number of people possible, those would be the 2 things I would employ. Movement therapy, and it doesn't really matter what kind as long as it's slow and progressive and graded, and mental behavioral health techniques such as cognitive behavioral therapy and relaxation, etc. So when you are able to break the pain cycle and allow someone an analgesic window to start them moving again, it can be literally curative. So that's an important thing to think about when you're considering interventional techniques. One of the things that I actually heard at this conference several years ago was this quote that I use all the time with patients: motion is lotion. And it is. Movement is incredibly important for most types of chronic pain. If the body stops moving, all kinds of things get worse. So I use that phrase a lot and talk to people about the utility of helping break their pain cycle and get them moving. Obviously, with that being said, and this is somewhat off topic, but you have to emphasize the importance of continuing to move. So maintenance therapy, not necessarily with interventional stuff, but maintenance with movement. However, if you identify a pain generator and the pain flares again in the same location, you can again use an intervention to help get them moving and therefore maintain their movement program. So I'm going to kind of start and go head down, and it just makes sense to me. Botulinum toxin for migraines has been extremely successful in my practice. I was sitting there thinking about the presentation earlier and trying to think of why botulinum toxin works so well for migraine sufferers, given what we know about it, and I don't know if I have an answer. Maybe somebody can give me one, but it does work very well. I would say in my practice, I'd say 70% of people who receive Botox for migraines get about 50% reduction in their overall headache burden. So it's something to, to think about. Another thing that comes up fairly infrequently is this atypical facial pain. So you'll have somebody that has burning or tingling pain in a specific nerve distribution, and oftentimes it'll be infraorbital or supraorbital or auriculotemporal. And those patients do very, very well with just small amounts of local anesthetic. You can also use a small amount of steroid in that area. And then you can do more advanced things like cryoablation, where you're actually freezing the nerve. You're giving it frostbite, essentially. The limitation of the local anesthetic and steroid injections is that, as you know, oftentimes they'll only work for a few weeks. You can get lucky and get some that work for much longer in a particular patient. But in cases where you've diagnostically addressed the pain generator by blocking one of these nerves, there are cryoablative techniques that are available. Botox actually works well too as a chemo denervation, so to speak, but it's really hard to get it paid for, unfortunately. Cervicogenic migraines are something that we see a lot. Let's see if it's on the net. Yeah. So you'll often see a patient who says, I got a lot of pain in my neck, and then it just goes right up over the top of my head, and I get a headache, and it ends up behind my eyes. That is, it's not a classic cervicogenic migraine, but it's something that results from irritation of the greater occipital nerve as it travels through these muscle layers at the base of the skull. And so these patients do very well with trigger point injections into the musculature, topical anti-inflammatory medications, sometimes oral anti-inflammatory and oral muscle relaxing medications, and you can functionally treat the underlying cause of their occipital neuralgia and their cervicogenic headaches just by addressing the musculature at the base of the skull. There's a procedure that I do called a suboccipital decompression that's kind of a glorified trigger point injection. It's done under fluoroscopy, but what it does is it places the medication not only in the muscle group, but between the muscle group and the nerve itself, and it uses hydrodilation. There's about 20 cc's, depending on the patient, 10 to 20 cc's of local anesthetic that's placed in there to separate the muscle from the nerve, and it works really well in these patients that have neck pain with associated occipital neuralgia. The other thing that can cause cervicogenic migraines is significant degenerative disease in the facet joints. And another thing that people don't think about is the fact that the third occipital nerve comes right across the C2, C3 facet and gives rise to part of the greater occipital nerve. So if you have patients with significant degenerative joint disease and osteophytes at the C2, C3 facet joint, it's not uncommon for them to have occipital neuralgia, and you can address it doing facet blocks there and ablations. You can do a third occipital nerve ablation. So this is one thing that I wanted to spend a little time talking about. The interspinous ligament is a target for pain management that a lot of people don't think about. So you'll have patients who come in and say, I've got this pain right here at the base of my neck. And they think it's a disc, because a lot of these patients will have degenerative disc disease. And then you, as a healthcare provider, will press on that area very lightly. And the patient will say, yep, that's my pain. Well, it's definitely not a disc, because I can't push on your disc that lightly. So what happens is you can get inflammation. It's called interspinous enthesopathy. It's inflammation of where the ligament attaches to bone, and it can happen anywhere in the spine. So the interspinous ligament is actually a relatively common pain generator, especially in widespread myofascial pain syndromes. And it really responds well to stretching, movement, exercise. And you can actually do, if you're relatively careful doing it, you can do a blind interspinous ligament injection. I mean, you can feel where the spinous process is, and you know the relative length of the spinous process, so you're not going to go epidural or get anywhere you're not supposed to if you're careful. And so simply doing a trigger point injection in that area can make a huge difference. The other thing that works well for these patients is topical anti-inflammatories. I'm actually a pretty big fan of topicals because of the relative risk reduction compared to orals, and because I'm fortunate to have a compounding pharmacy in Kalispell that's really inexpensive. You may want to talk to your pharmacist in your area, because I can get a 50-gram diclofenac DMSO mixture for 25 bucks. And what I found is that the other pharmacies in the area essentially are charging a lot of money on top of that just to make a profit. So it should be reasonably accessible to your patients to get a simple topical anti-inflammatory, and a lot of my patients really, really like it, and it's certainly safer than the orals. Epidural steroid injections obviously can be effective both diagnostically if you're talking about selective nerve root blocks using steroids, but also therapeutically. Epidural steroid injections are definitely overutilized, but in cases of clear nerve root irritation, in cases of spinal stenosis, they can be very effective. Trigger point injections obviously can work for myofascial pain. Again, botulinum toxin, when you can get insurance companies to pay for it for chronic muscle spasm, is extremely effective. And then spinal cord stimulation. We'll talk a little bit more about that towards the end, but spinal cord stimulation, the most important thing to remember about spinal cord stimulation is that by and large it is effective for neuropathic pain. It does not work well for most people for axial pain or classic nociceptive pain. So it's really utilized as a relatively late interventional approach for neuropathic pain, with some exceptions. In complex regional pain syndrome, it should be used pretty early. This is another thing to think about for patients with chronic shoulder pain. So the suprascapular nerve, which provides innervation to the back and part of the top of the shoulder joint, can be targeted for chronic shoulder pain, and it can be done so with quite a bit of success. If blocking that nerve provides significant pain relief, there are again ablative techniques, in this case cryoablation. You can freeze this nerve and provide several months, if not more than a year, of really good relief of a lot of shoulder pain. So something that people aren't aware of, may not think about. Obviously, intra-articular injections can be effective for degenerative joint disease. Nothing really new there. So, as in the low back, one of the most common sources of neck pain is facet arthropathy. In certain age populations, it's the most common cause of axial spine pain. And we're lucky when we find those patients because there's a really good treatment available. It's very simple to diagnostically numb the medial branch nerves that provide sensation to these facet joints, and then relatively easy to do a thermoablation. It actually uses microwave current. So radiofrequency ablations that you hear about, it's actually a microwave technique. So the tip of the probe emits microwave current, which heats up the liquid. And since we're mostly liquid, the nerve gets really hot. It's like giving the nerve a 3rd-degree burn. Heats up to about 80 degrees Celsius. Typically lasts between 6 and 18 months. But those are very, very effective for people with primarily facet-mediated pain. Noridian Medicare has made our lives much more difficult recently because they require 80% relief for the diagnostic nerve block. So you can get patients come in and say, well, doc, you got rid of 70% of my back pain. And I say, sorry, that's not good enough. But anyway, that's one of our frustrations. So, a lot more stuff here. So low back pain, as you know, is considerably more common and more complex than neck and upper extremity pain. Therefore, a lot more potential sources of pain and some other targets that you can think of. SI joint is something that we think about a lot with low back pain, and the way that I try to separate out SI joint pain from other low back pain is the belt. So if I place my hands on the patient's back, and your hands are typically going to rest right on the iliac crest at about the L4, L5 level, or their belt line. If the vast majority of their pain is below that, you should think about the SI joint. And there are a couple of pretty good tests for that. One is a femoral loading or Ostgaard's test. So you have the patient lie on their back, have them flex their knee at 90 degrees, and push straight down. And that is a pretty sensitive indicator for SI joint pain. Other thing, obviously, Fortin's fingers test, which is where you just press on the joint line. Not very specific, but can help. And there are a lot of things that can be done for SI joint pain. There's diagnostic and therapeutic injections, there are ablations, and now there's a minimally invasive procedure called an SI fuse that's become more popular. I can't say I have a lot of experience with it because I've only had a few patients undergo the procedure, but it's a minimally invasive fusion procedure that orthopedic and neurosurgeons are doing. Epidural steroid injections, again, overutilized, but can be very effective in specific cases of spinal stenosis, cases of disc bulges pressing on nerve roots. I will make a comment here about the traditional, what's called an interlaminar approach versus a transforaminal approach. Interlaminar approaches are kind of the midline epidural steroid injections that most people think of. They have two significant problems. One is you have to use a sharp needle, so the risk of dural puncture goes up significantly compared to a transforaminal approach. With the transforaminal approach, the angle of approach that you're using and the fact that in my case I use a blunt tip needle for the transforaminal injections makes the risk of dural puncture essentially zero unless I had a seizure and landed on the needle. But the other thing is that when you do a transforaminal approach, you're putting the medication closer to the pathology. So when we think about the pathology of what's going on here, except with spinal stenosis is a canal pathology from at least three different sides. With transforaminal approaches, you're dealing primarily with nerve root irritation. And the disc and the nerve root come together in the ventral epidural space. And when you do a classic interlaminar approach, midline epidural, you're just kind of shotgunning everything in the back of the epidural space and hoping it works. So I'll see a lot of patients who say, well, I've got this low back pain, and I've had epidural steroid injections, and they work. And you go back through the records, and they use like 240 milligrams of methylprednisolone. Of course it worked. It would have helped your shoulder pain. But their problem isn't in the epidural space. A lot of these patients turn out they have myofascial pain or they have facet-related pain. So that's why I said epidural steroid injections are very overutilized. They're, in some places, they're just, you have back pain, here, get an epidural. Whereas in my practice, it's really specifically for spinal stenosis and typically monoradicular pain, so with an identifiable radiographic target. We talked about medial branch blocks for facet-related pain, radiofrequency ablation, same thing that we talked about in the neck. Same thing, trigger point injections with botulinum toxin can be very effective. I'm actually thinking about putting together a study for this because I've never seen any sort of intervention that works so well for so many people that is almost universally not covered by insurance. And so I don't know why that is, but every person that I've ever been able to do Botox for chronic myofascial pain, well, I can't say every, let's say 80%, it's worked phenomenally well. So something to think about. You can get it covered typically with workman's comp. VA will cover it, some private insurances will cover it, but for that patient who has classic myofascial pain and knots in their back and they get great relief for a few hours or a few days from trigger point injections, and they've done the physical therapy and you've done the topicals and everything else, it's another thing to think about. Oftentimes you can actually, with focal areas, the cost of Botox or botulinum toxin is pretty low. So oftentimes the patient will be willing to pay out of pocket. Oh, and I forgot to say I have no relevant financial relationships to any of this stuff. Sorry. Lumbar sympathetic blocks. Let's talk a little bit about complex regional pain syndrome. CRPS is overdiagnosed, but that's a good thing because it's one of those diseases that you want to catch early. So if you have any question of somebody who has non-dermatomal pain and they're having color changes and temperature changes, and it's just way out of proportion to what it should be, consider the diagnosis of complex regional pain syndrome, get them moving, get them into somebody who can do sympathetic blocks, because it is one of the other few things in my field that I can cure. So if you catch it early enough, you can stop it. But if not, it's very debilitating. The other kind of take-home pearl that I'd like to give you guys, I mentioned earlier with the quadratus lumborum patient. Patients who have kind of diffuse low back pain, and you've worked up the paraspinous musculature, the multifidi, and they've done trigger point injections, and you've maximized your treatment there, and they still have a lot of back pain that just sounds myofascial, and it's in the right location. Think about the quadratus lumborum and the psoas musculature. Psoas musculature, they'll have pain in the low back and pain going down into the groin. It's kind of hard to demonstrate the physical exam test, but for the psoas, you have the patient hold their legs straight about 2 feet off the table and then press down on it and have them resist. And that is fairly indicative for psoas pain. Quadratus lumborum is kind of tough. You can have them lean against a wall and push against the wall, or you can have them try to arch their back up while lying flat. And those things can trigger that type of pain. The problem with these muscles is that in most patients, unless they're really, really thin, you have to use fluoroscopic guidance to accurately get them because they're so deep. But it can be life-changing for people when you finally find it. And then, again, the diagnostic value is you can have them go to a good physical therapist and say, hey, this patient has quadratus lumborum pain, or this patient has psoas major pain. Can you give them some specific stretches and exercises to deal with that? So that's another thing to think about for low back pain patients. Cluneal nerve pain is something that is uncommon except in those patients who have had a fusion where they harvested bone from the iliac crest. And the patient will say, my pain is right there at the top of my butt. And oftentimes it'll be burning or neuropathic in description. And it's because when they harvest the iliac crest, or bone from the iliac crest, they'll go through the middle cluneal nerves. And so you can block those, you can do cryoablations there, and it can make a huge difference in those post-fusion patients who have that fairly classic neuropathic pain right at the top near where they harvested bone. The only other time I've seen this is in patients who had trauma, blunt trauma to that area that's damaged the nerve. Spinal cord stimulation, again, really think about spinal cord stimulation primarily for neuropathic pain. There are some good results with spinal cord stimulation for failed back surgery syndrome patients where it gets their low back pain as well. But the way it works simply dictates that it works better for neuropathic pain. Interestingly enough, in Europe, one of the biggest indications for spinal cord stimulation is refractory angina, patients who are not able to, or who are not candidates for other treatments for angina. Works very well for that. We can't get it covered in the US for that indication though. But the other thing that it works very, very well for is pain that is the result of vascular disease, because spinal cord stimulation increases blood flow in the extremities. So it not only treats pain, but it helps with the vascular component. Peripheral nerve stimulation, that's really the only thing that peripheral nerve stimulation is used much for, except in subspecialty centers, is occipital neuralgia. So patients with occipital neuralgia that are refractory to everything else that we've talked about do very well with a nerve stimulator placed over the nerve. Yeah, we've kind of covered all this. So let me talk real briefly about, so this is the transforaminal approach that I mentioned. This is a good example because it's coming in really high in the foramen and you're avoiding the dorsal root ganglia. But this highlights the importance of, while I can't say that it is standard of care, it should be. All epidural steroid injections should occur with image guidance. It is standard of care in the cervical spine. Please, if you If you know of a practitioner who is doing blind cervical epidural steroid injections, please report them to the state board because it is absolutely against standard of care. It is important to have adequate training. Without making too many political comments, it is unfortunate that in this state, CRNAs are able to do these types of procedures with no significant training. It's important that you make sure that the person doing these things is trained, ideally fellowship trained, but at least board certified. It's really important. You wouldn't, given the risk, it's important that you know who's doing it. This is an example of an ablative technique for SI joint pain. So I mentioned that SI joints have an option of doing ablations, and this is one that seems to work particularly well. The problem with the SI joint is that unlike the facet joints, the nerves themselves have a variable course as they come out of the frame, and so you almost have to do like a carpet bombing approach when you do the ablation. It's called a cooled radiofrequency ablation. It uses heat, but the tip of the probe is cooled, so the lesion size is much larger. But this is a very good option for people with refractory SI joint pain. This is an example of a psoas injection. And we've talked about that quite a bit. Actually, it's psoas and quadratus lumborum. The quadratus lumborum is on the left, and the psoas is on the right. And those are typically about 2.5 to 4 inches below the surface, so they're tough to get to without, the psoas is virtually impossible to get to without x-ray. I'll talk very briefly, because we're getting short on time, I want to talk briefly about a couple of relatively new things for knee and hip pain. So in the knee, there are a set of 6 or 7 nerves called the genicular or geniculate nerves, 4 of which you can numb without causing weakness in the knee, but you can give pain relief. We've known about this for about 10 to 12 years, but we haven't had the ablative technology yet to reliably get them, but now we do. So people have a new option for chronic hip and knee pain. So you diagnostically block the geniculate nerves in the knee or diagnostically block the femoral and obturator branches around the hip. And if it works well, you can do an ablation for those. So for patients who are post-surgical or not good surgical candidates or refuse surgery, this is something that works really well. The procedure is called COOLIEF. That's the brand name for it, COOLIEF. But basically, it's a radiofrequency ablation for those particular nerves. We talked about complex regional pain syndrome. Don't wait till it looks like this. It's something that, like I said, it's fortunate that it's overdiagnosed because it's something that should be caught early. And spinal cord stimulation we've covered. And I think, we should talk about this briefly. Absolute contraindications for epidural steroid injection, anticoagulant therapy, have to be sure that 5 half-lives have passed for their particular anticoagulant before you do anything that can even hint at resulting in an epidural hematoma. Obviously any infection that's actively treated. One of the things about procedures regarding surgery is that for patients who have a diagnosis of complex regional pain syndrome and they're going to have a painful procedure, strongly recommend getting a sympathetic block done the day of or the day before the procedure to blunt that output to reduce the risk of the complex regional pain syndrome spreading or worsening. So something to think about that people don't often think about. A little note about sedation during procedures. The more sedation you give, the more dangerous the procedure. And so it is important to make sure that patients are comfortable, but it's more important to make sure that patients are safe. So in my practice, I would say 30 to 50% of people get some sort of sedation, typically a little bit of Versed and or fentanyl. But I do not feel that it's safe to have patients under basically a general anesthetic for these types of procedures, just due to the risk. Too many issues of nerves being hit when a patient could tell you if they were awake. I put a reference at the very end of the slide set that's a really good meta-analysis of interventional pain, the data that's out there, and kind of relative risk stuff. One of the things that I think about when I'm doing procedures is that, you know, in my 8 years of doing these and certainly well over 10,000 patients and a lot of injections, I've been good and lucky, and to my knowledge have caused 0 permanent complications with any procedure that I've ever done. But I guarantee I've killed more than one person with my opioids. So there are things to consider in terms of relative risk with this stuff. And again, these procedures are not just therapeutic. The utility of these procedures diagnostically can't be overstated. And that is the reference that I mentioned. So if you guys, if you want to have a look at kind of the best meta-analysis to date of most interventional pain techniques and the data that's out there, this is a good resource to have. Miles Day was one of my mentors at Texas Tech. Great pain doc, and wanted to thank him for some of the things contained in these slides. So with that, I'll take some questions. A microphone.
Hello, wonderful
Hi.
talk.
Thank you.
Can you speak to ketamine injections for both pain and mood? I'm doing ECT with ketamine, want to move to ketamine infusions, but also want to hear your opinion on using ketamine.
I think ketamine has some good data for complex regional pain syndrome. We have chosen not to do it because we just don't have the personnel. I mean, it has to be basically a monitored anesthetic at the doses that have been shown to be effective for complex regional pain syndrome. Beyond complex regional pain syndrome, I'm not really aware of any good evidence for other chronic pain syndromes, but I'm not the world's best authority on ketamine.
I have a question. I'm right here.
Yeah.
I'm the one with the microphone. I'm an osteopathic medical student, and I think that it's been great to be able to learn about more tools, and great that you're able to relieve so many patients' pain. And that's definitely a goal of mine as well. And especially hearing about the myofascial pain, that a technique that I learned recently was fascial distortion model. And I was wondering, and that we've learned some techniques with trigger points and psoas, and if you had considered as a tool in your tool belt of osteopathic manipulation, if that was something that you had considered.
So we have, in our practice, we have a massage therapist and a chiropractor. So the short answer is yes. First of all, chronic myofascial pain is present in at least 50% of my patients. I mean, it is incredibly common. The first thing that I tell them is movement is incredibly important. You have to restore the strength and flexibility of the affected tissues. And so we talk a lot about how to do that in a gentle way, because classic traditional physical therapy fails most of these people because it's too much and it hurts and they stop. We talk about massage. We talk about topical anti-inflammatory medications. Those are kind of the first line agents, the first steps in treatment. After that, if they're not responding well, I'll typically do trigger point injections. I'm not a big fan of trigger point injections other than diagnostically, because frankly, for a couple of reasons. One, this is something most people don't know. Almost every local anesthetic is myotoxic. Okay, so if you're doing trigger point injections, please use tetracaine. Tetracaine is one of the least myotoxic. Lidocaine and bupivacaine and all the ones that are commonly used are actually damaging muscle tissue. So that's one reason I'm not a big fan of traditional trigger point injections. Now, dry needling doesn't have that problem, and I like dry needling. I think it's a good technique. But the other reason I'm not a big fan is that it seems to be so short-lived. I mean, what the patient really needs is the treatment for the underlying issue, which is getting them moving again. You know, motion is lotion. Yeah.
Sorry, thank you.
Hello.
Hi.
My name is Terry Anderson, and we've talked about the risks of epidural steroid injections. There's no steroid approved by the FDA. The safety and effectiveness has never been established. And what we're watching in social media is the standard of care in Montana seems to be you have a back pain problem, multiple epidural steroid injections, maybe a fusion, then more epidural steroid injections. And so there's this ramp up, and it's actually creating the need for opioids, you know, because like myself, I'm fused, I have arachnoiditis, and now I'm at the end of the line requiring opioids. And we think there needs to be a better way to diagnose early on arachnoiditis, especially if there's been a dural puncture or a dural puncture during surgery or an injection. And so this is our concern because it's happening. Arachnoiditis is alive and well in Montana, and we want to put that on your radar. And then what do you have for options for once we've been through all these treatment options and there's nothing left?
So let me address that kind of in a stepwise manner. First of all, there are multiple studies that have demonstrated the therapeutic utility of epidural steroid injections. Second, the fact that steroids are not FDA approved for use in the epidural space is not nearly as relevant as a lot of people think. If you look back to the previous slide set, the first medication that we feel is indicated for neuropathic pain, my first line agent is nortriptyline. It's not FDA indicated for the treatment of neuropathic pain. Arachnoiditis caused by epidural steroids occurs, absolutely. It's incredibly rare. The bigger problem with steroids in the epidural space is particulate size. So for every one patient that may have adhesive arachnoiditis from an epidural steroid injection that was performed usually inappropriately with lack of imaging or inadequately trained people doing it, because in my practice, I've never knowingly put steroid into the dura. When you're in the dura and you inject dye, you see it. When you're below the dura and you inject dye. The bigger problem is the particulate size of steroids. So for every one patient that may develop adhesive arachnoiditis from steroid injection, there are hundreds of patients, and we're talking, it's incredibly rare to begin with, but there are hundreds of patients who develop because of large particulate steroid sizes and because of the very small arterioles in the epidural space, they develop occlusion of those arterioles, and they have either cord infarcts or nerve root infarcts, and they're paralyzed. So the more important topic is the understanding that non-particulate steroids should be used in the epidural space, or betamethasone, which has particulate sizes that are very, very small. Your last 2 points. One is earlier diagnosis. I agree. Right now, the only way we really have to diagnose arachnoiditis is, looking at MRI, and unfortunately, that occurs fairly late. Although, with history and the right presenting symptoms, it's pretty easy to figure out what's going on. The bigger problem with arachnoiditis is that, as with a lot of chronic neuropathic type pain, our treatment options are somewhat limited. And I think to go back to your last point, which is, what options do we have? Well, I mean, with arachnoiditis, the patient you mentioned who had back pain and ended up with a fusion and continues to have back and or leg pain, that's the poster child for at least trying spinal cord stimulation, because the evidence is out there, both financially and with clinical outcomes, that for that type of patient, spinal cord stimulation is superior to repeat back surgery. And epidural steroid injections, like I said, I've done thousands of them, and they don't work very well for most people for a long time. They work very well for most people for a short period of time, and they can be helpful diagnostically. But I would say out of every 10 epidural steroid injections I do, maybe 2 of them will last more than 3 or 4 months. So it's important to understand that repeated doses of steroids they can be risky. There are studies that suggest that even a single injection of steroid increases your risk of hip fractures. So Another thing to think about, and the thing that I think about in my practice is, do I have an option for this patient that doesn't involve more than a couple of steroid injections a year? But the other thing about, so one other thing to say about epidural steroid injections is a big hubbub a year or two ago that made Good Morning America, where a study was published on the lack of efficacy for epidural steroid injections. So they took people with moderate to severe spinal stenosis, and they did injections of steroid and lidocaine only. And what they found is that it made no difference. So a couple of important things to consider. Number one, that's a tiny subgroup of people with a specific severe disease of spinal stenosis. It's not indicative of people with monoradicular pain from a nerve root pressing on it. But with spinal stenosis, what happens, at least the best hypothesis for what happens with epidural steroid injections, because the point is they both worked. The steroids worked as well as the lidocaine, just not better. What we think happens with spinal stenosis and epidural steroids is a volume effect. You essentially, by injecting fluid of any kind in there, you're kind of breaking a pain cycle in some way. So to use a study talking about moderate to severe spinal stenosis, comparing lidocaine only, which worked, to steroids, which worked equally, is not a good way to make a statement about the role or the efficacy of epidural steroid injections. You can thank Dr. Oz for that one. Jeez. The guy who says we all need Tiger Balm and that'll fix our chronic pain. All right, any other questions?
All right, I've got two for you, actually. One, so I'm a primary care doc. I have a hard time convincing people to do the mental health part, so I want to know how you talk to people about that and if you tell them it's optional or not. And also, what do you recommend for primary care docs who have patients who have seen folks like you and get kicked out for inconsistent UDS or something else, refuse to go back?
Sure. So let me kind of pretend that I have a patient in front of me and we're talking about the role of mental behavioral health, and this is a conversation I have multiple times a day. I say something to the effect of, regardless of where your pain is coming from, it's all processed right here. Now, I haven't said yet all pain is in the brain, even though it is, because that's going to be misinterpreted by the patient. But I say that all pain is processed here, and there are things that we know that can be done here, tools that you can learn, skills that you can develop, techniques that have been proven in our patients and with large, well-done studies that can help reduce your suffering. And we have experts here who do that. And I would like you to go at least talk to them about some of those options. So I avoid words like counseling, like therapy. I'm trying to come up with a better term. We call them pain educators. They're really mental behavioral health specialists, but I try to avoid those things that give any sort of hint that the patient might think that well, you're saying I'm crazy or it's all in my head. So it really starts with language. It starts with how you introduce it. And then, it depends a lot on your counselors too, how they present it. I like, at least in those types of patients, to give the counselor a heads up saying, please, on your first visit, don't start by going into adverse childhood experiences, things like that hints at a more traditional counseling approach. I talk to them about, try to give these patients some tangible things that they can work on and then build on that. Second part of your question, it's a tough one. I think the short answer to it is that if a patient who is at my clinic in particular, who has signed a controlled substance agreement and who has had multiple violations of a controlled substance agreement, with the personnel and the policies and the skill and everything that we have, if we don't feel comfortable prescribing opioids to that patient, you shouldn't. It's that simple. And this is something, I was having this conversation with Pat earlier. It's the easy part of my job is this stuff. You know, putting things around people's spinal cords is nothing. The hard part of my job is when I think about the fact that I'm probably doing more harm than good when I prescribe these things. I can guarantee you that statistically I'm causing more harm by prescribing opioids. But when I have a patient sitting in front of me who's convinced me that these medications are helping them function, I have yet to reach the point in my career, unlike some physicians, that I can say, no, I won't prescribe them. But it's tough. This is not something that any of us take lightly. And that's something that I tell patients. You know, because pain is subjective, we just have such a difficult time monitoring outcomes. But if you have significant doubt, think of it that way. You know, the likelihood in a patient like that who has had risky behavior already, the likelihood that they're going to get more benefit than harm from chronic opioid therapy is low. And that might help. It's not easy, though, I know. The other thing I'll tell you is that, you know, in my experience with thousands of chronic opioid patients, those who have violated, who have convinced us to let them start over, about 95% of them do it again. So, you know, in those cases, it also you have to consider addiction as well. You have to offer the patient addiction services if you think that that's appropriate, because that's more addictive type behavior if there are multiple violations over a period of time. And those patients have to be approached differently. You know, failure with addiction treatment is expected. And we'll probably hear a little bit more about that, I think, tomorrow. Thank you, everybody.